Good afternoon. Welcome to Grand Rounds. There is no commercial support for today's activity. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. If you are viewing online, the link will be listed in the chat section. And if you're viewing after the fact, the evaluation link will be listed in the description section of the video. If you have a question, please enter in the Q&A chat and we will ask at the end of this presentation. It is my pleasure today to introduce Dr. Aditya Ghosh. Dr. Ghosh is a PGY-3 internal medicine resident who is passionate about cancer care, as well as community-based education initiatives regarding the importance of cancer screening and preventive care. Over the course of his residency, he's been a part of cancer screening awareness videos that were posted on NGMC's YouTube channel, has published a manuscript on adherence to NCCN Guideline-Directed genetic testing in patients with pancreatic cancer, and was recently awarded NGMC's Resident Researcher of the Year during the 2024 annual Northeast Georgia Medical Center GME Awards ceremony. Dr. Ghosh will be graduating from NGMC at the end of this month and will be returning home to Rochester, Minnesota to start work as a Senior Associate Consultant of General Internal Medicine at the Mayo Clinic. Please join me in welcoming Dr. Ghosh.
All right, good afternoon, everybody. Thank you for having me today. It's an honor to be here. Again, I'm Aditya Ghosh. I really appreciate that introduction. I'm excited to be here and kind of finishing up my last year at NGMC, and you know, it's a kind of bittersweet. This is going to be my last presentation at NGMC as a resident, so hope it's a good one. So my objectives for today, I want to identify the current problem with prostate cancer screening. I want to describe the dangers of excess screening of the general population, as well as outlining who in the community is at a higher risk for prostate cancer. Then I want to highlight prostate cancer screening guidelines, discuss how we should be able to interpret PSA testing, and then educate on what follows, what evaluation follows a positive screening test. Finally, I want to end with exploring what both we as healthcare providers as well as those in the community can do in order to improve prostate cancer screening awareness. So the current problem of where we are right now is that prostate cancer is the second most common cancer in males worldwide. The annual age standardized incidence is 30.7 per 100,000 persons per year. It's also the most common cancer in male persons in the United States, with an age-adjusted incidence of 113.4 per 100,000 persons per year. It's also the most common cancer amongst older adults aged 65 years and older. Most early prostate cancer is asymptomatic. The important thing to understand about early cancer when it's detected is that localized and local regional prostate cancer generally has a good prognosis. It's 100% 5-year relative survival in the United States. When prostate cancer is diagnosed at an earlier stage, the outcome is far better compared to when it's diagnosed at a later stage. And that also we'll get into as far as how the management changes depending on when it's diagnosed and how to follow it up. So the big question we have in the clinics is to screen or not to screen. Do we do PSA testing or not? That's the main question we have. I remember when I came to NGMC as an intern and we were in the clinics and there was the whole discussion about PSA testing. You know, we have our colon cancer screening, we have the low dose CT screening. Those are pretty nicely laid out and we feel pretty confident on how we need to move forward with those specific screenings. But when it comes to PSA screening, we would always tell that, hey, we've moved away from PSA screening for the entire population, and it's really a individualized decision. It involves shared decision making, and then we kind of just leave it there. So in practice, as an intern, I would do what I would try to do would be, okay, PSA screening, you're in that age range of 45 to 75. Would you like to get PSA screened? And the patient would say no, and I would say, okay, next question. And so the important part there is understanding who should be screened, what risk factors can lead to somebody being at a higher risk for prostate cancer, and would mandate a different approach to that PSA screening compared to the general population. So the important part here is understanding that there's been a declining incidence rate for low-risk disease that was temporally associated with decreased prostate cancer screening following a change in the 2012 USPSTF recommendation, which was basically a blanket statement against prostate cancer screening for the general population. However, data from the U.S. Cancer Statistics Database, spanning from 2005 to 2016, showed that while there was a decrease in rate of low-risk disease that had stabilized in males over the age of 75, the rates of regional stage and distant stage disease had actually increased for males aged over 50 years. So importantly to say, because we weren't screening, we weren't capturing these early and local regional disease, and instead patients were showing up with distant metastatic disease that is far more dangerous and has a far higher mortality. So analysis of the SEER database from 2004 to 2018 also demonstrates an overall increase in the incidence of metastatic cancer associated with an initial prostate cancer. So the association of the incidence and the screening of prostate cancer is an important part to explore. So among males aged 45 to 74, the incidence rate has increased significantly from 2010 to 2018. In males aged 75 or older, the incidence rate has increased as well from 2011 to 2018. So with all of this information, obviously in medicine, we're constantly in that ebb and flow of make change, wait for some more data points to come, wait for some more research to come back, analyze the research, plan, do, study, act. And in the act part, in 2018, USPSTF changed their blanket statement against prostate cancer screening, now switching it to a grade C recommendation for screening of males aged 55 to 69, which has altered screening practices and potentially could also alter those numbers of cancer incidents that we see. So as we delve into it further, it's important to get a sense of what's the clinical presentation of prostate cancer and why it's a little bit more tricky than some of the other ones in terms of overall understanding how to screen and who might be at risk for it. So the clinical behavior of prostate cancer ranges from screening detected, asymptomatic, only found on microscopic, well-differentiated tumors that may never be clinically significant to those that are clinically symptomatic, aggressive, high-grade cancers that cause metastases, morbidity, and death. Now that's a pretty scary spectrum of disease right there in terms of when we're saying already the other side of that spectrum is what we're talking about, the number 2 biggest cause of cancer-related deaths in the United States and around the world as well, that it can go from not really doing anything to leading to the deaths of many of our patients. And so that's really the important concept when it comes to screening and who should be screened and how should we go about screening. Most prostate cancers are diagnosed in the localized stage and are asymptomatic. However, uncommonly, prostate cancer may present with nonspecific lower urinary tract symptoms, or more rarely, hematuria, hematospermia, or bone pain. It's important also note there that for most males, lower urinary tract symptoms are mostly due to non-malignant conditions. So the danger that why we say that early cancer detection, early screening saves lives is when we get into this area of the complications that come with advanced prostate cancer. When we haven't been keeping a watch on it and you catch it too late, what does it lead to? The complications of advanced prostate cancer are pretty devastating for patients. They include urinary obstruction, prostatic bleeding, hematuria, hematospermia, and bone mets and other associated complications that are associated with those bony meds, including vertebral collapse or deformity, pathologic fractures, and spinal cord compression. So with all of that, the important part of understanding who should be screened differently from the general population, before we even get into what the actual guidelines are, it's just important to understand what predisposes certain people to a higher risk of developing prostate cancer and who should be looked at it a little bit differently. So as outlined by the National Comprehensive Cancer Network, factors such as age, race, specifically higher incidence and severity of cancer is seen in men of African descent. Genetics, we see a higher incidence associated with BRCA1, BRCA2 mutations, family history of cancer, obesity, and smoking. Now, when you see some of these risk factors, we end up seeing that there are a number of patients that we see in the clinic that we don't adequately advise when it comes to the shared decision-making component that you might be at a higher risk for developing prostate cancer. Therefore, PSA screening might be more beneficial in you. So just if there's one slide to take away, I would definitely take away this slide just to get familiar with, for all of us, with what what predisposes patients to be at a higher risk for developing prostate cancer. The important other side of the PSA test debate, which really has led to people going both sides of the paradigm, and that paradigm, pretty violently shifting over time, has been the risks that are associated with prostate cancer screening. Specifically, the question of overdiagnosis. So overdiagnosis refers to detection by screening of a condition that would not have become clinically significant in a patient's lifetime. The idea here is that when screening finds cancer that would never have become clinically significant, patients end up being subjected to risks of further screening, confirmatory diagnostic testing, and potentially treatments that can result in other devastating side effects. So along those lines, the abnormal results of screening tend to follow up need for prostate biopsy in order to determine if prostate cancer is present. The complications of prostate biopsy do occur in up to 2% of males, and these can include infection, pain, bleeding, and urinary obstruction. And overdiagnosis is of particular concern because most males with the screening detected prostate cancers only have early stage disease. And where that becomes an issue is those patients that have that early stage disease end up getting offered the same aggressive therapy that somebody would have if they were more late stage disease. So more aggressive therapies that have long-lasting adverse effects, such as impotence and urinary incontinence. And so there's this ebb and flow that goes with who should get screened, why should they get screened, how should we be screening, and when we do screen these patients and we get a result that it shows potentially higher risk for prostate cancer, concern for prostate cancer, what do we do after that? And so we'll try to get into a little bit of that now. So when we get into the guidelines, the USPSTF has acknowledged the importance of shared decision-making for PSA screening recommendations. The part that they kind of put together there when they made their recommendation is we need to have appropriate discussions between the clinician and patients regarding family history, race and ethnicity, comorbid medical conditions, and importantly, almost most importantly, the benefits versus harms of screening versus treatment. The important part is that exposing everyone to PSA and digital rectal exams, PSA testing, leads to unnecessary procedures and further invasive testing. So being a little bit more discerning with which patients exactly should we be doing PSA testing in the first place, and then following that PSA testing, how do we follow that up? So the interesting part when we get into the guidelines is that different societies have a little bit of different ways of kind of laying out what their guidelines are. And it might be a little bit difficult to read this, but this is the snapshot from the NCCN, National Comprehensive Cancer Network. These are their guidelines. They're kind of like one of the big kind of law-abiding things from the cancer societies. They kind of come together, they say what the evidence is, and they adjust their guidelines every few years. But right now, this is where their guidelines stand. Specifically, when it comes to early detection evaluation, it's important to say that for patients aged 45 to 75 with average risk, or if they're 40 to 75 years old with higher risk. So when we say average risk, we mean if they had any one of those few factors that were mentioned on that previous slide, smoking, obesity, family history of cancer, or if they were 40 to 75 years old and had high risk, including patients who are of African-American descent, those with germline mutations, and those with suspicious family history. These two groups should get PSA testing. And then the follow-up of that PSA testing has its own kind of guideline as well, depending on where the PSA lines up. So in those patients, if their PSA was less than 1, they would recommend repeat PSA testing in 2 to 4 year intervals. If the patient had high risk high risk, had a PSA less than 3, or if they had average risk and the PSA was 1 to 3, then they would recommend repeat testing every 1 to 2 years. Importantly, if the patient had a PSA over 3 or very suspicious findings on digital rectal exam, they would recommend referring to a urologist for consideration of a prostate biopsy. Where this gets a little bit interesting and a little bit more nuanced is when we compare the NCCN to the USPSTF, which tends to be the guidelines that a lot of us in internal medicine follow when we're in our clinics in terms of just giving us the internal medicine viewpoint, the most important guidelines and understanding of how we as internal medicine doctors should proceed with taking care of our patients. And importantly, why I like to point out this slide and specifically highlight it in this way is that, again, as they said, in 2018, after the evidence showed that with decreased screening for prostate cancer, with decreased PSA testing, we were seeing an increased influx of patients with late stage disease. The USPSTF actually moved that paradigm back from saying no need for prostate cancer screening to saying now we call it a grade C recommendation. Now, I just want to take a moment to pause on that because that grade C recommendation is important for all of us to be able to understand. It's shown in yellow. We as doctors don't like C's, and so we tend to say, okay, grade C, move on. We don't need to do it. Or shared decision making means, you know what, I'm a little bit less likely to do that. I don't want to give something that has a C grade to my patient because I'm only about the A's. We're high achieving individuals and we try to give our patients the best care they can. And USPSTF is telling me that that's a C grade, so why should I do it? The important part to understand is USPSTF has the C grade, which basically means as a blanket statement for the entire general population, we might not recommend that everyone in that age group should get PSA testing. However, as you can see within that recommendation, it has an entire paragraph, detailed paragraph, basically saying some of the stuff we talked about before, that you should have that shared decision making with your patients. And specifically, if they are at a higher risk, they fall into a different category. They are not the general population. They are a high-risk population and should be discussed even more thoroughly in terms of the need for or the potential benefits that would come with PSA testing in that population. So when it comes to the PSA test, the decision to offer testing for prostate cancer should be based on each individual's estimated life expectancy, as well as the probability that a clinically significant cancer may be present. Again, that goes back into the risk factors. If they're a general population, there might not really even be a benefit there, and that's where that shared decision-making is. But if they're a high-risk population, there's a possibility that they could have a clinically significant cancer, and you might want to consider doing PSA testing further. You want to engage patients in shared decision-making with an informed choice regarding prostate cancer screening based on the benefits and harms of the PSA testing. The potential benefits of screening include a small reduction in prostate cancer-specific mortality, but the effect is still somewhat uncertain and inconsistent across trials. For patients with high risk, including African-American patients, patients with germline mutations, BRCA1 or BRCA2, or patients with family history and first-degree relatives, they recommend starting prostate cancer screening based on shared decision-making at age 40, greater than or equal to 40. For patients who are older than 70 years old or have a life expectancy less than 10 to 15 years, prostate cancer screening isn't recommended because, again, it goes back to the idea of would the treatments extend their life or will we be doing more harm by subjecting them to treatments when they might not even live 10 years, even if that prostate cancer hadn't been treated. And for patients less than 40 years old, prostate cancer screening is not recommended. So when it comes to the PSA test, some of the important things to understand is exactly what it is, how it can be confusing, and what can lead to a low test, what can lead to a high test. So specifically, the PSA test, the prostate-specific antigen, measures the amount of PSA molecules in a patient's blood. And that's important to understand and appreciate just because, okay, sometimes we'll see a high PSA value, but to jump on the fact that, okay, that might increase your concern that this patient has prostate cancer, but that alone does not mean they have prostate cancer. It just means that they have a high level of that PSA molecule in their blood. So while it can be a sign of prostate cancer, it can also be falsely elevated in the setting of urinary tract infections, prostate stimulation, vigorous exercise, and certain medications as well can increase that PSA level. So it's important to understand just how that test works, and to also, when you're taking that history of when you're doing that PSA test, to also be able to elicit some of those other historical factors that would tell you one way or another why the patient might also have an elevated PSA. So importantly, with the PSA test, there's no single threshold for defining an abnormal PSA value. There's considerable variability in normal PSA, and studies do not conclusively identify a single approach to it. that's applicable to every patient. So again, you'll see here some of the age-specific reference ranges depending on the different age range of the patients. How that is interesting in that it contrasts, again, this is kind of from USPSTF, but how that contrasts with NCCN, which kind of just said it as a blanket, less than 1, 1 to 3, and 3 are kind of those PSA values that they kind of look at as their search and reference ranges, which would dictate how they would want to proceed with further testing. So here, understanding that 40 to 49 years old, patients will range in PSA from 0 to 2.5 if they didn't have some of those other factors like urinary tract infection or vigorous exercise. 50 to 59 years old, 0 to 3.5. 60 to 69 would be 0 to 4.5, and then it's up to 6.5 for 70 to 79 years old. So also being able to understand that with age, patients' PSA value goes up. And so being able to also appreciate, okay, if you see a higher PSA value in an older patient, how would you want to go about following that up? Would you want to immediately send them to your urologist, or would you want to proceed with more watchful waiting and kind of do a repeat PSA in a few months or in a year's time? That's an important part to consider when you're making those judgments. Prior to urologic referral, it's always recommended to repeat an elevated or increased PSA test in a few weeks to confirm that that level remains elevated. Again, because there are those other things that could naturally just have happened in their day-to-day that led to an abnormal increase in that PSA, we want to make sure that that part is ruled out and this wasn't just a false positive. If modifiable factors that temporarily raise the PSA are present, these factors should be addressed prior to repeating that PSA. So if the repeated PSA is within the normal expected value and it's not increased by more than 0.75 compared to that prior year's value, they don't need any further PSA testing. They're considered okay, unless there's a palpable nodule, induration, or asymmetry on digital rectal exam. And so we're just about to get into that one. So the digital rectal exam, DRE for short, is generally not recommended anymore as a routine screening test for evaluation of prostate cancer, or in the rectal area, and for evaluation of the prostate or rectal area in the absence of symptoms. That's an important part, is if they aren't having symptoms like urinary or rectal symptoms, it's not really that useful of a test, because for us specifically, it's understanding that the digital rectal exam can really only detect tumors that are in the posterior and lateral aspects of the prostate gland. And so doing a DRE when there's not really those symptoms that would be seen by having some sort of mass effect on the urinary tract or the rectal tract, those again would just say that there's no point in really doing a DRE here. Tumors not detected by DRE include almost 25 to 35% of tumors that are either not reachable by DRE methods, as well as small stage T1 cancers that are not palpable. And important to also note that many males have symmetric enlargement and firmness of the prostate, and this is more frequently seen in BPH, benign prostatic hyperplasia, compared to cancers. So what follows a positive cancer screening? So we have this PSA test, it seems abnormal, patient is asymptomatic themselves. What should we do after that? So the important part is when it ranges in that 3 to 10 range, again, kind of combining both of those recommendations from USPSTF and NCCN, you want to go further onto the ideas of risk assessment, magnetic MRI imaging, or other serum or urine biomarker testing. That's where you could really begin talking about, okay, we might benefit from a urology referral as well, because they'd have the full kind of workup already ready to go. For most patients with locally advanced prostate cancer suspected on DRE, or a PSA greater than 50, or for patients not pursuing definitive therapy, you can even consider a limited biopsy without MRI at that point, based on that PSA test alone. So for all patients with localized prostate cancer prior to biopsy, it's important to perform an MRI, because if an MRI is positive, you want to consider combined targeted biopsy with additional sampling of the prostate around the lesion to see if there's any kind of mass effect, or if there's any metastasis around or spread of that cancer outside of just that focal region in the prostate. However, if the MRI is negative and there's a low clinical suspicion of prostate cancer, you can consider actually foregoing the biopsy at that point and just continue with PSA monitoring. Again, the important part of all of this is you're doing this stepwise process and trying to follow this regimented stepwise process to prevent the patient from having unnecessary invasive procedures that could lead to their own complications and further troubles for potentially a cancer that's not even there, or potentially a cancer that doesn't need that type of aggressive evaluation. Again, with all of that, it's important to estimate life expectancy and evaluate health status and the comorbidity to determine this testing strategies. So getting into when to refer to urology, again, it becomes really when there's a high clinical suspicion for prostate cancer because of a high PSA or an abnormal DRE. Patients who present with symptomatic metastatic disease usually do not need a prostate biopsy, and depending on where that metastatic focus is, rather than targeting the prostate, which is a very sensitive area, you could actually go to one of those metastatic foci and biopsy those to confirm the diagnosis. The objective of a urologic evaluation, when we would refer as primary care internal medicine out to a urologist, is primarily to determine, one, whether a prostate biopsy is indeed warranted, whether additional testing may obviate the need for biopsy at the time, as we talked about before, as well as, again, just setting the stage for what's the appropriate timing for reevaluation. So again, this also gets into shared decision-making, but being able to kind of discuss the pros, cons, the risks, benefits of getting a prostate cancer or of getting a prostate biopsy. Specifically, that biopsy may be warranted if the patient has a life expectancy over 10 years and any one of the following: either an elevated PSA, an increase in PSA by more than 0.75 compared to the previous year, or on digital rectal exam, there's a noted nodule induration or asymmetry. If the patient has significant comorbidities that limit life expectancy, a prostate biopsy to evaluate the possibility of asymptomatic prostate cancer is usually not warranted. So again, that shared decision-making piece is very important when it comes to prostate cancer, when it comes to PSA testing, when it comes to whether or not you want to get a biopsy, kind of every stage in that process, you want to have that patient involved in that discussion. So the really important part to understand about prostate cancer, again, is that that PSA test is a screening test. It's not the confirmatory test. You need a biopsy and you need a tissue diagnosis in order to say this is in fact prostate cancer. And the methodology of going about actually diagnosing prostate cancer is through what's called the Gleason grade. It's based solely on the architectural features of prostate cancer cells and correlates closely with clinical behavior. A higher score indicates greater likelihood for having non-organ confined disease, as well as worse outcomes after the treatment of localized disease. And based on the growth pattern and degree of differentiated, these tumors are basically graded from 1 to 5, with grade 1 being the most differentiated and grade 5 being the least differentiated. So the Gleason score is derived by adding together two numerical values for the two most prevalent differentiation patterns. So important there to say is that when they're looking at that histopathology slide, they're basically looking for different differentiation patterns and basically trying to say, okay, what's most prevalent, and is it more differentiated, less differentiated? The less it is, the worse that grade. So as an example, if a prostate biopsy consists predominantly of a grade 3 and a secondarily grade 4, so basically most of it was grade 3 pathology, and then there was a little bit of grade 4, and then an even little bit of maybe grade 5 or grade 1, they wouldn't even go with that. They'd go with what are the two most common that are seen on that slide, and they'd add those together to get what their Gleason grade is. So the Gleason score has been the preferred system for grading tumors, and it's been incorporated into the tumor node metastasis staging system for prostate cancer. So this is just kind of showing a little bit of the histopathology going from grade 3, which again is a little bit more differentiated, and then as you get into grade 4, you see it's becoming more and more differentiated, and as you get to grade 5, it's kind of just very infiltrated with those cancer cells, and even more differentiated there, less differentiated. So with that histopathology diagnosis of prostate cancer, the Gleason score information was incorporated into a new histologic grade group. So the histologic grade group basically takes the Gleason score and divides them into the different groups and basically says, okay, 1, 2, 3, 4, 5, basically simplifying it down to be able to say, overall, what's the prognosis of your patient, so that we're able to have a better, more accurate way of being able to tell our patients what's the prognosis of their disease. What's important to understand is that grade group 1, 2, 3, 4, and 5, as you increase obviously in the grade, you decrease in the survival rate. So going with grade 1, they have a 5-year survival rate of 95%. Grade 2 drops down to 83%. Grade 3 drops down to 65%. 3 and 4 are actually pretty similar, with 3 being 65 and grade 4 being 63%. And when you get to the point where it's grade 5, there's a 35% 5-year recurrence-free survival rate. And so the importance there is really understanding this kind of is part of that whole why there's been the more recent push for let's get back to screening those who are at higher risk for prostate cancer, because diagnosing it at an early stage, as we can see from some of these numbers too, can really save lives. The important part here is kind of being able, they've done work and research on being able to kind of combine these different Gleason scores along with the PSA testing to be able to basically say what's the probability of 10-year overall survival. This was specifically in white males over the age of 70 undergoing radical prostatectomy. And basically the important takeaway there is when they underwent that testing, based on where their Gleason score was, again, as you kind of go across the rows, you're basically seeing as you go from Gleason 7 to Gleason 8 to Gleason 8 to 10, you see a decreased amount of survival in each one of the rows. But interestingly, what you also see as you're kind of comparing the different rows to each other, I'm trying to see if this, oh. Yep, so that works. So again, as you see here, along this column here, we're talking about the different PSA values. As the PSA values have gone up in these patients who've already undergone that radical prostatectomy, important to understand that that can even be its own kind of prognostic indicator for decreased survival in this patient population. So kind of as the PSA testing after they've received this, this treatment, as that follow-up PSA testing goes up, their survival goes down. As the Gleason test, as the Gleason scoring on that initial disease, regardless of undergoing radical prostatectomy, as the disease scoring goes up, we also see a pretty dramatic drop in the survival based on that higher Gleason score. So how are we doing about prostate cancer in Georgia specifically? Georgia is one of the leading states diagnosed of prostate cancer with an annual incidence of 132.6 per 100,000 patients compared to the national average of 109.9%, 109 patients per 100,000 from the timeline of 2015 to 2019. This was seen basically from the NIH. They did state cancer profiles and they broke it up across the different states. And over the period from 2015 to 2019, they kind of compared how did these different states all do. And more specifically, prostate cancer has the largest rise of cases in the state of Georgia compared to all cancer types. So again, this is kind of just showing that across the board, you know, all cancer sites that, you know, we're seeing that there's a falling rate change here. But when it comes to the liver, oral cavity, pancreas, we're seeing increase specifically in Georgia. And the biggest increase from year to year over the past 5 years has been the incidence of prostate cancer. So getting to that last question of what can we do? So it's a two-way street. When we talk about shared decision-making, it only works when the knowledge is shared. It only works when both sides are knowledgeable, both sides understand risk benefits. And so being able to understand what we as healthcare providers can do to educate our community, but also advocating for other sorts of changes, other sorts of ways of increasing awareness about prostate cancer screening so that the community is on the same page. So us as healthcare providers, being able to educate our patients on the benefits and risks of screening can lead to informed decisions based on values and the patient's preferences. We also want to make sure we're providing culturally relevant educational materials that may benefit underserved minority men who are at a higher risk of developing prostate cancer. One of the examples that was actually really interesting over the past few years, as a concerted effort to try to increase the awareness about the need for PSA testing in African American men. They did what was called a ham and a haircut, which was basically they gathered a group of African American men who went to the same church, and they brought them out for a haircut. They also got a free ham, and while they were getting that haircut, the discussion that would go on during that time was about PSA testing, prostate cancer, who's at higher risk. And so important kind of educational interventions like that and other things like conventions and things where we can have those discussions with our community, town hall settings. Those can all make a big difference in being able to help our patients as well. Also being able to adopt that increased uptake of the expected management, understanding the benefits that come with active surveillance or watchful waiting rather than jumping right to aggressive treatment. It may mitigate the treatment-related harms of overdiagnosis and prevent further shifting of that paradigm going back and forth from people being so scared about the risk of overdiagnosis and what that overdiagnosis can lead to, leading to the problem that they're not doing PSA testing anymore. So if we can be more cognizant of the fact that, okay, if their PSA test is elevated, how do we follow that up? What is the next step? Do we really need to be doing a prostate biopsy? Maybe, maybe not. Do we need to be going the full court press when it comes to the aggressive prostate cancer treatment? Maybe, maybe not. But having that idea that, again, informed decision-making, but also case-by-case basis, and being able to understand in what cases would active surveillance or watchful waiting play a bigger role in providing better care for our patients. And again, getting back to that fact that shared decision-making, again, works only when the knowledge is shared. Our community needs to know what's going on too, and they need to be able to advocate for themselves appropriately as well. And so patients will benefit from becoming familiar with their own risk factors that were outlined before on those earlier slides. And importantly, we need to kind of get the community involved in this, because sometimes men don't like to go to the hospital and or go to the clinics and get their checkups. And sometimes it needs that family support to say, hey, you need to make sure you're getting checked up on this. You might fall under this risk factor based on other issues you've had. You had family history of cancer. So even that slight nudge can lead to early cancer diagnosis and things. So those are my references, and thanks everybody.
Do we have any questions from the audience? Just raise your hand and I'll run over to you. We do have a question over here.
Thanks, Ghosh, for the awesome presentation. I think it's interesting. It's not really a question. It's more of a comment. You know, my dad falls into that high risk factor prostate cancer category. And a year ago, he had noticed his PSA kind of creeping up a little bit. And, doctors were told him, not to worry about it. And he was just very persistent. And he went to other doctors and demanded a little bit more investigation. And he actually ended up having prostate cancer that was invading into his nerve. So, I guess what I'm trying to say is that, it takes just knowing the risk factors and really listening to the patient and not just brushing them off because it's a grade C recommendation by USPTF. So thanks for the presentation.
I'm sorry to hear that, and I hope he's doing okay.
Thank you for your comment. We have another question up here.
Great job, Dr. Ghosh. I like the passion with which you presented this topic. You can tell this is an important topic for you, and it's important for us to know as providers. And the topic itself, so it's not screening in the traditional sense, but it's modified screening that we should all be aware of. Certainly all these cancers, comorbidities that are affecting patients' livelihood, we should know the risk factors for and how to go about diagnosis and management. So yeah, it's great awareness to us and for providers not to just brush this off. That like prostate cancer, you don't screen for anymore, but yes, if they do have the risk factors, you do investigate further. So yeah, good topic.
Thank you. We do have another question over here.
Thanks a lot, Dr. Ghosh. I had one question about the Gleason scoring. If you can go back to that slide. I think it was grade 2 and grade 3. They appeared similar, but one of them was more
grade 3 and grade 4, I think, yeah.
It was a table, sorry. Yeah.
Oh,
This one, yeah.
Uh-huh.
Grade 2 and 3, where the Gleason pattern is 3 plus 4 and 4 plus 3.
right.
And it seems like the 4 plus 3 is more
So that-
severe. So
And
can
that's
you
a very
explain
good point. So what that basically comes down to is, again, this is a very important point you make, because also you'll see it written in different ways. You'll see the Gleason score sometimes written, sometimes you'll see the Gleason pattern. What sort of importance should we put into that? It's really important for us to understand what the one number plus another number means exactly. And so I think I put it on a previous slide. But kind of what it really represents is basically what's the primary and what's the secondary kind of pathology. And so the difference when you're saying between 2 and 3, again, even if you see some of the numbers, they're actually pretty similar, but really why it's considered different is you're saying the primary pathology for grade 2 is a grade 3, and the secondary pathology, so a little bit smaller amount of that pathology, is grade 4, versus the opposite for that grade group 3, which is that the primary pathology, a larger amount of that pathology is grade 4, and then a smaller amount of that pathology is grade 3. And so the importance why that's such a nuanced kind of an important understanding, and I'm glad you brought that up, is again, that's kind of why they moved away from the Gleason score alone, and sometimes even the Gleason pattern, because those numbers could be very deceiving. You see a 3 plus 4, you see a 4 plus 3, and you think, okay, they're probably the same thing, right? Like they both equal 7. But the important part is to understand that this is why they moved to the grade group, is saying that grade 2 and 3, even though they were so similar in terms of that kind of appearance and score and everything, the difference in the recurrence-free survival rate was 83% for grade group 2 compared to 65% for grade group 3.
Thank you.
Great question.
Do we have any, oh, we have a question back here. Can I go this way? Thank you.
Great presentation, Dr. Ghosh. It's a very important topic. And I was wondering, in all your research for this presentation, what are your thoughts on the current USPSTF recommendation, giving it a grade C recommendation, especially for African American individuals? And then do you think maybe there should be a qualifier or something for that recommendation, or in the future? Because I've also read on this topic as well that not only are we seeing more cases coming up since that recommendation was put in place, but also some of them are a lot higher grade that might have been caught a little bit earlier in the disease process if we had continued screening like we were. So what are your thoughts on that?
It's a fantastic point, and honestly, that's kind of at the heart, I think, of a lot of the current debate as far as how USPSTF presents things. One of the big questions is basically USPSTF, the way the grading system is currently, it's like talks about general population. That's what it's referring to, is how we should view this test for the entire population. So grade A and B, entire population should get it. Grade C gets a little bit more nuanced, where accurately it does say that the entire population doesn't necessarily need or would benefit from PSA testing, and that's where the individual decision making kind of plays a role, understanding the risk factors. But importantly, again, that's where they kind of get into the weeds of it's a grade C rather than a grade D or grade I, because there still is that evidence that says in certain populations with those high risk factors, they definitely absolutely should be getting PSA testing. So I'll just read this out, because this is basically again, where it gives that grade C, it shows it in yellow, and then it has this whole paragraph, which is exactly what you're talking about, Dr. Barker. So it basically says, for men aged 55 to 69, the decision to undergo periodic PSA-based screening for prostate cancer should be an individual one. Before deciding whether or not to be screened, men should have the opportunity to discuss the potential benefit and harms of screening with their clinician and to incorporate their values and preferences into the decision. Screening offers small potential benefit of reducing the chance of death from prostate cancer in some men. However, many men will experience potential harms of screening, including false positives that require additional testing and possible prostate biopsy over diagnosis. In determining whether this service is appropriate in individual cases, patients and clinicians should consider the balance of benefits and harms on the basis of family history, race, ethnicity, comorbid medical conditions, and patients' values about the benefits and harms. Clinicians should not screen men who do not express a preference for screening. So with all of that, kind of like what you're talking about, I think there would be a benefit of, in some way, if there is a way of just saying, hey, like, but for this patient population, you know, all the patients who fall into that patient population or into that risk factor category should definitely be considered to get PSA testing. Yeah.
Is there a particular shared decision-making tool that you feel like might be, sorry, just to repeat part of the question, is there a particular shared decision-making tool that you've used in the clinic that you think might be a really good tool that we could use in the clinic? Because what I have found personally when I talk to patients is when you let them know the evidence that, yes, it is a grade C recommendation, and that part of the reason for that is, you know, there's risk for operative complications, symptoms. Many of my patients, when they hear that, they don't want to go any further, but they may be higher risk. And I do let them know that, but ultimately it does come down to their decision. So I was just wondering if there's any tools that you had in mind.
There's not, that's a great question. There's not specifically a tool, I would say. I would say the important part is that in that shared decision-making is also being able to discuss it in that way in terms of benefits and harms, and specifically saying, if you as a provider, if you as a physician are thinking this patient falls into that higher risk category, really being able to explore that with that patient about what that higher risk category means, what prostate cancer when it's diagnosed early versus diagnosed later means, being able to get in a little bit into that nuance of why we screen for prostate cancer, screen for any cancer for that matter, being able to kind of say that's really what the benefit is, and this is just a blood test that would start the process, or in other ways basically say we don't need to do anything further. And so a lot of patients that I've had, when they've had that initial kind of, oh, what could the future entail? When you make sure that they're properly educated on kind of all those factors, they're actually more than willing to kind of say, you know what, I'd definitely be willing to pursue that PSA testing, just because it's a blood test as opposed to, you know, jumping to the biopsy. Definitely one of those things there that I do build out, you know, it is exactly that, okay, depending on how this results back, it might potentially require further testing in the future. And potentially if we do see some concerns, it could lead to treatment that would be explored at that time. But the important part is to say kind of benefits and risks and harms, really. Mm-hmm.
Any more questions or comments? We have one right here.
Great presentation, Dr. Ghosh. You mentioned history of prostate cancer as one of the history of cancer as one of the risk factors, and BRCA mutations. So anybody who has in their family history of breast cancer in somebody and possible risk of BRCA mutations, would you say that those patients, let's say they don't have any other risk factors except for that specific one, do you recommend, or is there any data on its association with prostate cancer and getting them tested for the mutation prior to going down the route of getting prostate biopsies and all those things?
Yeah, you've opened up a whole other discussion, but that's a great question there too, because specifically there, it's actually combining two things together. Okay, they have a family history of cancer. Could they also potentially have that BRCA mutation? That becomes its own question in terms of guideline-directed, BRCA1, BRCA2 mutation screening, genetic screening, And it really depends. It's usually a case-by-case basis, but there is, data out there in terms of the benefits, depending on that degree of history, family history of either breast cancer. But specifically there in terms of how it would advise how you need to go about testing and should you do further testing. Usually it wouldn't be one of those things that it would prompt need for genetic testing prior to getting PSA testing. It would be one of those things that you would discuss with your patient in terms of if they need to get both. If screening in their case is not only, okay, PSA testing for prostate cancer, but really genetic screening for looking for BRCA1/2 mutations that could potentially lead to further down the line, either within them or in their children or family members, other medical issues.
Okay, thank you so much, Dr. Ghosh, for your wonderful presentation.
Thank you.